Cancer. What causes it? Ways to detect it, and how to treat and even prevent it. In the Know with Phil Hayes starts right now. One of the major health maladies plaguing our world today is cancer. The Center for Disease Control in Atlanta says that lung cancer is the highest cause of death in both men and women at an alarming 52% rate each year. From our diet, to our level of exercise, to even our exposure to the sun. Cancer is a staple that impacts us all. We all know someone who's been impacted by cancer in one form or another, either from getting it or, unfortunately, from passing on from it. There are many places where we can go to receive education, to be informed, and receive treatment if need be. The Tate Center is one such place, along with Chesapeake Oncology, both located in Maryland. Dr. Russell DeLuca and their staff work diligently and persevere to research cancer and effectively treat it. And some of the things that they're finding from their research, in a word, astounding. The Tate Center, in conjunction with Chesapeake Oncology, is one of the leading hospitals in the nation with regard to treatment of blood, brain, breast, lung, and prostate cancers. With its location in Glen Burnie, the Tate Center exists so that many cancer patients in the region will have accessible primary care. The center has established an entire course of treatment for each form of cancer, beginning with lung cancer. One of the central philosophies of Chesapeake Oncology is prompt, accurate diagnosis and staging of malignancies by providing state-of-the-art chemotherapy infusions and radiation therapy. The specialty of oncology has developed greatly throughout the years, and many treatment modalities are available to treat various degrees and types of cancer, including surgery, radiation, chemotherapy, hormonal, biologic, and immune-mediated therapies. Within Chesapeake Oncology, one of the chief physicians treating patients within the Anne Arundel County region is Dr. Russell DeLuca. With 5 facilities, 9 physicians, and over 25 years of experience to his own name, Dr. DeLuca's will to provide quality care to the community, along with his detailed, skilled mode of treatment, has won him rave reviews from both his peers and the cancer research profession in general. Dr. DeLuca's commitment to success and well-being will ensure that Chesapeake Oncology will remain at the forefront of cancer research and treatment for years to come. And we're here with Dr. Russell DeLuca, who is one of the chief physicians here at Chesapeake Oncology in Annapolis, Maryland. Dr. DeLuca, welcome.
Very nice, thank you.
Tell us about Chesapeake Oncology.
Well, Chesapeake Oncology is a multidiscipline oncology group here in Maryland. We actually have 5 offices. Our primary location is in Glen Burnie, and we have other locations in Baltimore, Columbia, and here in Annapolis, and over on Kent Island. It comprises 9 physicians, 7 medical oncologists, and 2 radiation oncologists. As I said, our main office is in Glen Burnie at the Tate Cancer Center. That's where we conduct a lot of work working with surgical specialists with breast cancer and gastrointestinal cancers and lung cancers, and cutaneous cancers as well.
Cutaneous, how's that?
Yeah, like melanoma and aggressive skin cancers, other aggressive skin cancers. So that, and we've been able to do that utilizing a process of what's called multidisciplinary care, where all the specialists will meet on a regular basis to help facilitate and move things along quickly so there's not long gaps of hopping from doctor to doctor to get something accomplished.
Right.
So that many times I will hear about a patient in the conference and I'm seeing them in the office either that afternoon or within a couple of days.
Wow.
And I already know some of the story. I think we've always been very much on the forefront of introducing new therapies as they came available, either through research protocols and or those studies that came through onto the market.
Okay.
Sometimes they are the general standard of care because that's what's been proven to be a benefit, and sometimes they're a little bit ahead of what there is when there isn't a clearly defined standard of care.
Right. Because I know a lot of people out there watching will probably say, you know something, maybe I should go see a doctor, but there's a skeptical nature in all of us. I mean, everybody's fearful. You know, we go to the doctor. Sometimes we find out things, you know, maybe we don't really want to find out.
Exactly.
You know, how would you go about trying to entice people to go, I mean, perhaps not even you, just any doctor, period, to make sure that, you know, if indeed something is wrong, if they do a self-diagnosis and they find a lump perhaps in their chest or something?
I think if you look at what are the things that somebody can do to try to prevent or try to find their disease early, it's looking at within themselves and their family to start with. Are there diseases in the family that I'm aware of that do tend to run in families and that I should seek out medical care to look for? Family history of colon cancer, family history of breast cancer, you know, these type of things, which by doing mammogram screening for breast cancer and or doing genetic testing, getting the colonoscopy that nobody wants to have, but is an essential part of doing those things to try to find things early are the best things that people can do to try to get to things early. Not smoking, not starting smoking, stopping smoking. Yeah, smokers always continue to have a higher risk for lung cancer, esophageal cancer, head and neck cancer, bladder cancer, kidney cancer, pancreatic cancer. But stopping always tends to reduce that risk.
Now, I know recently we just lost Steve Jobs, and of course, within the past year, I believe Patrick Swayze to pancreatic cancer. I understand that that's one of the hardest types of cancer.
Pancreatic cancer is indeed one of the hardest cancers because it hides with where it is in the body and in the upper abdomen, near the back, so that when somebody has symptoms, it's already advanced.
And what might some of those symptoms
Pain.
Okay.
The symptoms of pain that radiate into the middle of the back or even up to the shoulder, when pancreatic cancer presents in that fashion or they present with being yellow, jaundiced, it's already locally advanced disease. All right, so that aside from people who have a very strong family history of pancreatic cancer, where you might think about doing a screening CAT scan, and that tends to be very rare, it's very hard to pick it up early. One of the frustrating things is that even when pancreatic cancer is caught early, it still tends to spread. So even doing surgery isn't enough, and you have to do additional chemotherapy and sometimes radiation. So that is a very difficult. Most of the times people will prevent with advanced disease, and usually the prognosis is less than 6 months. And yet, having said that, we've had a number of patients who've lived several years. Being careful about the kind of treatment that we've offered and given them over the years. And so we've been able to see patients have had significant benefits in those interventions.
A lot of it tends to stem from diet and exercise, and even in some cases, just people being out on the beach without any, sunscreen or something like that.
So that with melanoma, histories of severe sunburns at an early age, or prolonged sun exposure over many years, they get skin cancers, they can get melanoma. using a healthy diet that there has a balance in cutting down on saturated fats and meats, although you need some for a good balance of proteins, helps when we're talking about issues of colon cancer and rectal cancer.
Okay.
It also has some value with regard to breast cancer because of weight issues and obesity and then diabetes that adds up to these things.
Right.
That affects hormone levels, and that's where that ties into breast cancer.
I see.
With regard to melanoma, there are people who have funny looking moles. If you know you got funny looking moles, you should be seeing the dermatologist regularly. Or you look for something that has changed in its shape, size, color. Those are the type of things that somebody needs to look at this early on.
Okay.
Patients who have other illnesses where their immune system has been suppressed. Kidney transplant, liver transplant patients, heart transplant patients who are on these suppressive therapies for many years have a higher incidence of malignancies. And so paying attention to those things and making people aware that, it's only a skin cancer. It's only a skin cancer. It's only a skin cancer. Except when you're immunosuppressed and those skin cancers become extremely aggressive.
How does the Tate Center and Chesapeake Oncology work in conjunction to try to promulgate some of these things as far as getting these things out, getting this information and educating people basically?
Part of what we do is getting out into the community and doing community talks. Communicating with the primary care physicians, as I just did with the melanoma talk earlier this month.
Okay.
The conferences that we have are always open to any and all the doctors available, depending upon their interest. And so we get lines of communication that way to spread that word. And what things they do in other materials that are published by the hospital that get out into the community of things to look for, things to watch for, advertisements for screening procedures. We've had skin cancer screening clinics in the past, as well as screenings for other cancers. Okay. And so we get the word out to the community.
What are some of the drawbacks that you're finding with regards to the actual research, and how to effectively treat patients?
One of the major problems there with the way research is conducted is the regulatory factors that go into play very much make it very difficult in getting programs out available to the community and making more patients, making more of the new research available to patients.
So it's okay to do the research and basically get the grant money, get the funds, you do your research, you come up with conclusions and solutions, you go through your scientifics and all of that, and then you run into problems, you run into roadblocks with regulatory agencies who would not want this to, I won't say not want, but who would try to throw some red flags in
They throw wrenches and red flags, I would say, in your ability to make it more available, those research protocols. Oh yes, we have the protocols, but only if you go to this doctor. Or only if you come to this hospital. But I thought we were working with those people. Yes, but. And it's a very difficult issue because you have to make sure everything is done properly. And it takes a lot of overseeing, and as much as there's resources available, those resources are limited. And people are limited in terms of their ability. You can't have a research nurse assigned to cover practices at 4 different hospitals. Alrighty, to get those all in. One person can't do that. And so it's those kind of things that make it difficult, or just the whole process of getting a research protocol put into place can sometimes take many months of checking on this and checking on that and making sure everything is in order. And that's also what makes difficult and why it sometimes takes forever to get those things. And yet, a lot has been able to be accomplished by the work that's been done.
Have you found that with regards to insurance companies and, as I say, I see you smiling already. Have you found that, I mean, between HMOs, PPOs, I know
insurance
that
companies,
insurance companies,
else.
I know that you just want to treat people.
Right.
I know that, but are you finding that they are as much a part of the barrier as
Right.
some regulatory agencies?
Yeah, our biggest difficulties are the people who don't have any insurance or don't qualify for insurance.
Don't qualify.
Yeah.
Okay.
You know, they make money, but they don't make enough, so they can't get help. But they don't make enough to have their own. And or the people who do have their insurances, and the insurances seem to try to, rather than working to try to get the treatment, try to find ways not to allow treatment or not to allow follow-up. As a way of, well, we've got to watch our cost and how many steps do you have to go and how that time delay then interferes with things. Or, you know, drugs that come out on the market and are available for a doctor to prescribe, as the law says, as he feels is justified, based on his knowledge and his work of what may be helpful to the patient. They will then cover, well, it's not FDA approved, but it's on the market, but it's not FDA for that indication.
Right.
And we'll say, well, here's all the research that's been done over the last 10 years on this drug, in this disease. I said, well, we'll prove it for a couple months, but then we'll have to relook at it again. And so sometimes it may take several months to get a drug available to a patient.
And in that several months.
Now, hopefully they're stable for that.
Right, exactly.
So you have those things along the way. So it can be you go to a research meeting, you hear the latest results of a new breakthrough therapy on a drug that's on the market. And then you go back and you have your patient and you can't treat them with that new therapy because it hasn't gone into their review. They haven't accepted it as their treatment. And so that clearly makes things very frustrating.
So that prevents you from being able to effectively
treat the patient that you know and what you think. You know, as much as my staff spends time sending my notes, sending the records, sending the information. No, oh, you need to write a separate letter. You need to talk to so-and-so. Oh, you've got to do it at this point in time. So stop what you're doing with the other patients who are waiting so you can do this.
Exactly.
And so those are the difficult issues that then arise.
What would you advise someone who might be a bit, apprehensive about coming in to see the doctor after that?
It's a very difficult situation that we face. There's been a tremendous growth in options for care for patients with advanced disease. As an example, with kidney cancer, up until about 7-8 years ago, there was like nothing that worked.
Wow.
And then you had a flurry of new drugs come onto the market, so that there's 6 or 7 drugs now that have an indication for treating advanced kidney cancer that have had impact in improving survival in patients. And so that those things are changing, and seeing the doctor, finding out what's what, finding out what all the options are. Finding out when you need to go to the research center for the latest available, because there are things for that particular cancer, or how to intervene.
Okay.
How to get, because there may be limits in terms of medicine, but there may be surgical interventions, radiation interventions that work together. And how can you do that unless you get to see the doctor who's going to be able to coordinate and put those things together for you? We see a lot of people with blood disorders of all varying degrees, not just cancer.
Right.
And then they could be iron deficient. They could be minor things that are major health problems for them that we can take care of, or their laboratory tests are abnormal, and so the doctor sent them to get our opinion, and we can reassure them that, no, you're fine. So yeah, I see the fear element when they don't even have cancer,
Exactly.
let alone when they do have the issues of cancer. A lot of times what I'll tell my patients, you know, they're worried, they're afraid, they're scared. I said, my job is to be worried and figure out what's wrong and figure out what I can do. And I tell them, your job is just tell me what's wrong. Tell me what's bothering you. Tell me what the problems are. Report to me. Show up for your appointment. Show up on time. If I ask you to get a test, get the test done. So that I can then have to be worried and figure things out.
If you could highlight one initiative in your years of research, if you could think of one that you would be just, you know, beating at the chest left and right to highlight, what would that be?
What I'm most proud of the Chesapeake Oncology is the medical oncology, major medical oncology component was able to do with the Tate Center and getting, you know, working again with radiology, you know, radiation therapy, and then getting the surgeons all together and forming that focus. We've worked closely with the people at the University of Maryland who are part of Baltimore Washington Medical Center, and I've brought them in to further integrate those services along the way.
Dr. DeLuca, I know you're a very busy man. I know you've been running around the office all morning. Thank you for the time that you've given us today, and thank you again so much. It's been very helpful. Stay tuned. We've got more of In the Know with Phil Hayes after this. Cancer is the third leading cause of death in the United States and a global epidemic that affects millions. Research for a cure obviously underway, but there's hope. With organizations like the Tate Center and Chesapeake Oncology, and researchers and physicians such as Dr. Russell DeLuca, I believe that we can look forward to a day when what is connotatively known as the Big C will soon be defeated and eradicated. I'm Phil Hayes, and you're in the know. We'll see you next time.